Thank you so much for that kind introduction, Nives, and kudos to the Pain Society of Alberta for this incredible pivot to a virtual meeting, and just gratitude for Katie in sharing her experience thus far, and I think has really set up a wonderful place to start our conversation over the course of the next few days, but also this session in particular. So I want to go back to kind of the origins of the field of pediatric pain. I'm guessing many people listening and attending and other speakers today really come from that lens of chronic pain or acute pain in the context of adult care. And our field of pediatric pain is reasonably young relative to the broader pain field, really having its origins in the late 1970s. And you can see from this bibliometric analysis led by Dr. Lena Case a number of years ago, looking at all of the peer-reviewed scientific publications in pediatric pain from 1975 to 2010, that there was exponential growth. What started out as dozens, a few papers here and there, has really continued to explode over time. And you can only imagine how this has continued over the past 10 years. Dr. Patrick McGraw, in a paper he wrote in 2011, talked about the modern history of pediatric pain. And I pulled this quote from it because I think it's particularly relevant to the origins of the field, but also where I think we need to go and where we really have started to move. And what he said in his paper was that the modern field of pediatric pain was born out of a marriage of science and public concern. And this was really new science that was coming out around pain experiences of newborns, and a mother whose baby who was born premature underwent surgery without any analgesics, just with paralytics. And what Pat continued to say in his paper was, without science, the public outcry of that mother and others would not have had a knowledge base. But without the public outcry, the knowledge would have languished for years before being adopted. So it really is this partnership between science and lived experience coming together where real change and real impact can occur. So I really think this patient and family partnership is the game changer. One of a colleague I work with who is a real leader in patient engagement in Canada shared this paper with me to really shift language from patient-centered care to partnership in care. Seeing people with lived experience, patients, family members as partners of the care team and equal members of the care team to engage in those decisions, really moving beyond involvement to co-building and co-designing. And the same principles apply to us in the context of research as well. And this definition of patient engagement, sometimes called patient and public involvement by an organization called Involve in the United Kingdom, it's often cited, and it talks about research being carried out with or by members of the public rather than to, about, or for them, as we have traditionally done. So this is a real shift at one end of the spectrum from patients as participants or people with lived experience as participants, now shifting towards more advisors, collaborators, equal members and co-designers of research projects, even moving at the other end of the spectrum towards patient-led research that's really supported by healthcare providers and researchers, scientists. And this is really an emerging area, although it is the kind of new norm. It is our standard now. It is best practice. So if it's something you're not doing, you're falling behind the time. So it's really important to take this approach. And the science around this has really started to grow as well. And what we can see when we engage patients and families as partners in health research is that it's likely to enhance quality and appropriateness and relevance throughout the research process. It's more effective, efficient, and meaningful research to patients and families, so people who are using the research evidence in their everyday lives. It increases the likelihood that research will be taken up in clinical care, which then ultimately will lead to better outcomes. And this is really important because there are incredible gaps, sometimes called the valleys of death in health research, from basic science to clinical to clinical research, and then from clinical research to actual practice and what happens in every day. And some estimates suggest it can take up to 17 years for that translation to occur, which in the context of children is an entire childhood. So it's much too long for us to wait. So engaging with patients and families as members of teams is likely to decrease that time and make it more likely that research will be taken up into clinical care more quickly. And then it avoids us wasting research funds and efforts in areas that are not important to patients or their families or people who were living with the condition we are looking to improve. So with this in mind, I started when I was a postdoc with Dr. Jennifer Stinson in Sick Kids several years ago, the Partnering for Pain project. And our goal with our initial project was really to co-build a sustainable patient engagement strategy to guide pediatric chronic pain research and practice in Canada, really embodying that mutual respect, that inclusiveness, those underlying principles of quality patient partnership. And we had some funding from the Canadian Institute of Health Research to do this, along with a number of the chronic pain clinics for kids across Canada. And one of the major outputs from this project was to conduct something called a priority setting partnership. And if you're not familiar, it's a methodology put forth by the James Lind Alliance based in the United Kingdom, which really engages people who have traditionally been excluded from research priority setting, from deciding what should be studied. And that's really patients and families and healthcare providers. So we put together our national team, which was comprised of researchers and healthcare providers in pediatric pain across the country, but also a number of youth with lived experience and parents who lived across the country and had different experiences with chronic pain. And we chose the James Lind Alliance Priority Setting Partnership because it's identified, there are lots of ways we can look at how we create priorities in research. But the James Lind Alliance methodology in particular is identified as being very robust, which we know, from a research kind of methodological standpoint really matters. It's strategic, it's objectively based, and importantly, it's inclusive and aimed to promote equity in patient voices. So it really puts that lived experience kind of first and emphasizes the equity and the need to be inclusive in that regard. So we published our paper in CMAJ Open along with patient and parent partners who co-authored that with us. So there were 4 steps that guided our priority setting partnership. And at each of these phases, we included Canadians who have had chronic pain during childhood, family members, and that included siblings and significant others like boyfriends, and multidisciplinary healthcare providers who actually work with these youth and families every day. And our first step was a national survey where hundreds of Canadians across the country just submitted an answer to what priorities, concerns, or questions would you like answered about chronic pain during childhood. And from that national survey, there were more than 540 suggestions or priorities that should be considered. The next step in our process was that our team turned those 540 priorities into research questions. So we combined kind of duplicates, multiple ideas, things that could kind of hang together, and actually turned those suggestions into a research question. So those became 112. Then we sent those back out to a smaller group of Canadians from those 3 groups again, and asked them to rank each one for how important they were. So to rate not important to most important or very important for each of those research questions. And from those across the groups, we identified the top 25. And then those were discussed at an in-person consensus meeting that took place in Toronto at the end of 2018, where this group of youth, parents, healthcare providers reached consensus on the top 10. And we brought people from across the country. We worked with our patient and parent partners to identify what types of diversity, what types of representation is really important to have at that table for this group that determines the top 10. We also wanted to evaluate how good of a job did we do with patient engagement. We used a tool called the PEAT, which was developed by Julia Abelson at McMaster University, who is also a great leading voice for patient engagement in Canada. And I just pulled out some of the items from that measure. So you get a sense when we asked people at the consensus meeting, what their level of engagement and value in the process was. And 5 is the highest score for strongly agree. So you can see that, the vast majority, if not all, either agreed or strongly agreed that they felt they were able to participate, express their views freely, felt confident that the final list we arrived at reflect what matters most to people with lived experience with chronic pain as a child or a teenager, their family members or clinicians, that their input would make a difference to our project, and that their input would direct the future about chronic pain in children and teens in Canada, and that it was a good use of their time. So lots of lofty goals, but people felt like we had done really quality engagement, which was wonderful. So I'm going to share a video with you. And I've just realized, I think when I shared, I did not share with sound. So I'm just going to do that again really quick and show for you just a video about our project to give you a sense of what we did. And so you can hear from some of the voices of people who participated themselves. My name is Katie, and I'm a psychologist, and I'm the lead for the Partnering for Pain project. Chronic pain in children is a really significant health issue, and it's really, a lot of research has been done to date and made huge strides over the last 40 years in understanding how pain is assessed and treated in children. But we've really left out one of the most biggest expert voices in this in deciding what research should be done, and that's really of patients and families themselves.
I've always thought that there's a gap between research and patients and what they want to see researched and what they understand from research. I was in the beginning really encouraging people that I knew in my community to respond to the survey. So it ended up with 500 plus answers, and now we get to bring this all down to 10 priorities. So it's very exciting to see.
As a parent, I have to say I've felt helpless a lot of times along the way in what I could do to help Catherine. So when we had the opportunity to get involved in this research project, we jumped at the chance, and we've been involved since day one, to come together in a room with people from rural and urban and different age groups, different dynamics. There's a lot of variation in the voices in that room.
And it's been a fantastic opportunity to come into this project. I always say at many points in my career I am often schooled by patients and families, and that's happened to me today.
Being here has opened up my eyes about what options there are nationally in the rest of the world.
And as a mom of a child who is suffering with chronic pain, it helps me to see there is hope at the end of the tunnel.
Well, I think that this is just the beginning of everything. This is the spark that will ignite a wave of future in the research world.
I just want to say thank you so much for inviting me. I learned a lot, and I learned a lot about people and myself, and I just want to say thank you that you invited me to this wonderful event.
So one of the things that we did after we identified the top 10 priorities is we really wanted them to be actionable by policymakers, by health research funders, and by health researchers. So one of the things that we did was we learned about this methodology called evidence and gap maps, which really are directed towards putting scientific information and evidence into a way that can be actioned. So what we did is to create our evidence and gap map is we reviewed all of the published systematic reviews for any type of chronic pain intervention published in the past 20 years for kids. And we reviewed the quality of each of these systematic reviews. And what we found that we could include in our evidence and gap map were 50 systematic reviews, including 2 clinical practice guidelines. And here's what our evidence and gap map looks like. You can see, for each of the rows, they pertain to different types of interventions. So psychological interventions, physical, pharmacological, other, and then interdisciplinary interventions. And across the top are different outcomes from the PED impact guidelines that talk about, how effective are treatments in each of these areas, or these are important areas for us to touch on. Each of the bubbles, the different colors represent different quality, with the more red or pink color representing critically low quality, up to the darker green or teal representing high quality. And the size and number reflects the number of systematic reviews in those areas. So what you can see is that most talk about pain intensity, and even just listening to Katie talking about earlier, less focusing on function, which we know in the context of chronic pain is really where we need to be putting a lot of our efforts before we might start to see a decrease in pain intensity. And you can see areas where there are incredible gaps. Sleep, there was very little research, economic factors, even things like adverse events, which are really critical for us to pay attention to, or treatment satisfaction. And then there are areas like physical interventions where there have been fewer research studies. And for those of us who work kind of in chronic pain care, and speaking from all the people with lived experience I hear from as well, physical interventions are key to chronic pain management. And there are many systemic reasons, for example, that physical therapists are generally as a profession less likely to get PhDs than psychologists per se. So there's just less research happening in those areas. So there are lots of reasons why there are gaps, but really important ones for us to note. The other thing we did is we mapped the science onto those top 10 priorities to identify, where do we have enough evidence for policymakers to start making really active decisions, and where are there gaps? And what you can start to see is there's the most evidence of the top 10 for psychological treatments, but there are many areas for which there is very little or only poor quality literature, or where there's none at all. And 2 big things that ended up in the top 10 list, really driven by the youth voices at our consensus meeting as well, pertain to school. So how does chronic pain impact academic performance, and how do we support vocational planning, and what strategies do we use to educate school personnel? So some real gaps in those areas that are really critically important to youth and families. The approach that we also took through our project is really working together in partnership with people with lived experience to make a difference, to generate awareness and interest about these, to create open dialogue with researchers, members of the public, policymakers, decision makers, and really facilitate adoption of these priorities. So these are photos with me, with some of our youth or parent partners at various stages, participating in a lobby day on Parliament Hill, presenting at scientific meetings, and sharing with the Canadian Academy of Health Sciences as they were working a few years ago to develop a national strategy for chronic pain. And because of one of our patient partners, Justina Marianagam, she sits on the advisory for the Canadian Pain Task Force. Our Partnering for Pain priority setting work showed up in the first report of the Canadian Pain Task Force a few years ago. And my greatest learning from this work is that their voices have been the most important in ensuring impact from the top 10 priorities and really bringing them to life. This top 10 priorities project has really directed the future of my focus in research and care, and really working to do that in a continued patient partnered way. So we have a grant I'm leading now looking at innovations in virtual care. I'll tell you a bit about which we know is happening everywhere in a more accelerated way because of the COVID pandemic. And we're also working together to co-design pediatric transitional pain services, and really doing that in a multi-stakeholdered way, and many partnerships where I think this work really can have impact. So I just thought I'd share some of our findings from our virtual care project. Our goal was to identify best practices in the first phase of our project for virtual care to support youth with pain and their families. And our team has youth, parents, healthcare providers, and researchers. And we did a rapid systematic review and found 16 scientific articles that were published in the past 10 years. And here's what we know. Already. There's lots we don't know, but here's what we can say. That virtual care is acceptable, it's reasonable, it's effective, it ensures better access to care, and it's underutilized, especially for things like symptom assessment and psychological treatment. It should be freely available across all technologies, so telephone, apps, websites, video conference. It needs to include some training, terms of use, guidelines for both health professionals and youth and families. It must use a secure infrastructure, should be developmentally appropriate, which in pediatrics is really relevant. It must meet ethical standards of care, and it should be transparent in communication. So some apps and other things deliver automated messages that look like they're coming from a healthcare provider, but perhaps aren't. The best platforms we can choose need to be user-friendly and acceptable to youth and families. They must be backed by science, and they should involve youth, families, and health professionals, so end users in their development. We need to ensure that they're individualized or customizable, that they're providing comprehensive pain care, that they're using multimedia content, they're meeting accessibility standards. There are many areas of intersectionality around chronic pain and other things. So and disability and accessibility. So we need to ensure that they're supportive and accessible for all families, and that they should be able to integrate social and peer support. But what we didn't find is any standard practice guidelines for implementation and evaluation, a lack of evidence showing the effectiveness that they can address all concerns identified by youth and families, that we need more knowledge about its limitations and suitability for all aspects of care, particularly for things like a physical exam or physical therapy. And we need to consider potential harms and impact on the therapeutic relationship. It requires strategies to enhance engagement. It's very different than in person. And we need to have better ideas about how these integrate into clinical care pathways, when and how to advance to face-to-face care or not, and how do we document and share a bit more about all of this in the electronic medical record. The second phase of our project that's ongoing, we're creating an interactive evidence and gap map that really maps out all different virtual care solutions across a stepped care continuum, from apps up to virtual pivots in tertiary care using video conferencing. We've done a scientific literature search, we've done an app and website search, and we had a call in partnership with SCIP and the Canadian Foundation for Healthcare Improvement for innovations in virtual care across Canada to support youth with pain. And our merit review panel for that is next week, which is exciting. I want to shift a little bit and talk about solutions for kids in pain in my last part of the talk. And for those of you who aren't familiar with SCIP, it's a national knowledge mobilization network that's really working to improve children's pain in Canada through coordination and collaboration. I'll show you a brief video about this group as well.
Canada is a world leader in children's pain research. But did you know it can take up to 17 years for research findings to be put into practice? That's a whole generation of children who miss out on the benefits of information we already know. What we know now is that 2 out of 3 children in hospital undergo painful procedures without any pain management at all. 75% of parents say they don't know how to manage their children's pain. Veterinarians get 5 times more training in pain than people doctors. And only a few Canadian health institutions have made a certified commitment to better pain management. This matters because pain that isn't treated well harms children's brains and bodies, is a struggle, and can be traumatic for families and health professionals, and costs the healthcare system time and money. Scientists have found many ways to manage pain, but most people don't know about these treatments. That's why at Solutions for Kids in Pain, or SCIP, we're working to improve children's pain management across Canada. We are a national knowledge mobilization network that is bringing together researchers, patients and caregivers, health professionals, 48 different health institutions, including all the children's hospitals in Canada, and over 100 partners from around the world. Our goal is to get knowledge about children's pain into the hands of people who need it faster. If you're a scientist or researcher, patient, caregiver, health professional, policymaker, or part of an organization or company with unique expertise or technology, you can help. In fact, anyone can. We all have the opportunity to be a champion for kids in pain. Visit kidsinpain.ca to find out how you can get involved.
So our goal, our vision is really to support healthier Canadians through better pain management for kids, and to do that by mobilizing evidence-based solutions through coordination and collaboration. We work kind of in four main areas of activity, which are to address readiness, create resources and share evidence, to facilitate institutional change, to produce tools, create new tools and promotion, and to generate awareness and urgency around the issue of pain for kids in Canada and around the world. And through those efforts, our outcome is to improve children's pain management, really focused on Canadian health institutions, and not just the specialized children's hospitals, but really throughout all levels of care. We have a great team. SCIP was envisioned and brought to life by Dr. Christine Chambers and Doug Maynard, and we're supported by a wonderful team, including a great patient engagement coordinator who's someone with lived experience herself. We have 4 regional hubs across the country. Dr. Samina Ali, who's speaking next, is our phenomenal Western Canada hub lead at the Stollery Children's Hospital, but lots of wonderful other colleagues across the country. And we also have a full-time knowledge broker at each of these sites who really work to on the ground to improve pain care and facilitate SCIP's goals. And we're a patients included organization, which means we have people with lived experience from our board of directors down through every activity that we're doing. Lots of partners. So if you're a partner and you're interested, or someone with lived experience, please join us. And we're doing things, I could show endless activities, but one of the things we're working on right now is creating a new health standard with the Health Standards Organization for pain care for kids in Canada, and lots of other promotion of practices with partners in different platforms. The last thing I want to talk about very, very quickly is a new Lancet Commission in Pediatric Pain that just came out this week and is really being launched today at a conference in Europe. And it's really focused on delivering transformative action in pediatric pain. I was very privileged to be an author on this along with some other Canadians. And really critically, there's 4 people with lived experience who also contributed to this. There's 4 goals that have really come out of the Lancet Commission, which around the future we really envision will be based. And really simple, but really complex ideas. So how do we make pain matter, make pain understood, make pain visible, and make pain better? And things like improving equity, stigma, many of the things Katie talked about in her initial introduction really come up as areas that we really need to continue to improve and continue to make transformative change, despite our advances over the past 40 or 50 years. Lots of acknowledgements and gratitude. This could be 10 slides, so I haven't put any particular name, but please feel free to reach out to me. If you're interested more in SCIP, lots of information there, and in the loop is our newsletter. You can check it out on our website and sign up. And if you're a patient partner, there's a tiny URL to come SCIP with us as part of the organization. And just one last plug for another great pediatric conference that's coming up. It's free to people with lived experience through the Hospital for Sick Children and a number of other partners. That's taking place in November.